Okay, welcome to the deep dive. Today, we're plunging into a corner of medicine that's, well, it's as complex as it is fascinating. Skeletal dysplasias. We've got the material you shared with us right here, articles, research, all your notes, and we're going to use it as our map for this, our mission, to really unpack what these disorders actually are, see how they reshape the skeleton, maybe get a handle on the incredibly detailed ways they're classified, and walk through the step-by-step process doctors use to figure out what's going on.
And it's quite a task navigating this landscape because at their core, skeletal dysplasias are defined by these developmental abnormalities of the skeleton. It's not just one thing, but a huge, incredibly varied group. Heterogeneous is the medical term. They range so widely in severity, from relatively mild issues to conditions that are unfortunately incompatible with life at birth.
That range, that's part of what makes it so challenging, isn't it? And here's where it gets really interesting. When you dive into the material you shared, you see just how many there are. Are we really talking over 400?
Over 400 recognized forms, yes. That number alone tells you something about how tricky diagnosis can be. And while each specific condition is rare, very rare individually, collectively their birth incidence is actually quite significant, something around 1 in 5,000 births. So it's a field where the collective impact is much, much larger than any single rare disorder might suggest.
Absolutely. A big, intricate topic. But that's exactly what the deep dive is for. We're going to help you navigate it using the information you've put right here in front of us.
Oh.
Okay, let's unpack this. So let's start with that fundamental definition again. Developmental abnormalities of the skeleton.
Yep.
Given, like you said, over 400 forms. How on earth do you even begin to classify them? Where do you start?
Well, historically, it was, let's say, simpler, largely because we just had less information, less technology. The initial approach was quite broad. Doctors would often classify patients based just on their overall body proportions. Were they primarily short-trunked, where the torso is the main area of, disproportionate shortness, like in conditions we now recognize as Morquio syndrome, or were they short-limbed, with the arms and legs being the most affected, which you see in a more common form like achondroplasia.
Right. And looking at the images you included, you can really see that visual difference. The picture showing achondroplasia clearly highlights the shortening in the limbs, particularly those upper arms and thighs, the proximal segments. That has a specific term, doesn't it? Rhizomelia.
That's correct, yes. Rhizomelia specifically refers to that shortening of the proximal limb segments, the humerus and the femur. And you contrast that with, say, Morquio syndrome, where the trunk is much more severely affected relative to the limbs. It leads to a very different overall look, even though both involve short stature.
So simple visual proportion was the starting point. But reading through your material, it's obvious the classification has evolved, well, dramatically.
Especially with advances in things like next-generation sequencing, NGS.
Exactly. With increased understanding and, crucially, the ability to identify the underlying genetic causes, the number of recognized disorders just exploded. The most recent nosology, that's basically the standardized classification system from 2019, it lists 42 distinct groups, covering 461 skeletal disorders. And what's remarkable, really, is that for 92% of these, a pathogenic genetic variant has actually been identified. That's huge progress.
Wow, 92%. That's incredible.
It is. And it's interesting how the basis for classification shifted over time. In the slightly older 2010 nosology mentioned in your notes, those initial groups, I think the first 8 listed, they were already being classified based on their molecular cause. So disorders related to the FGFR3 gene, for example, or those affecting type 2 collagen. But other groups, especially the later editions, were still classified based on the more traditional clinical presentation and, importantly, what was visible on radiographs. It was a sort of transition phase.
That makes a lot of sense. You classify based on the best info you have at the time, right?
Right.
And speaking of what you can see, the material you provided introduces some really specific descriptive terms. They seem crucial for pinpointing which part of the skeleton is affected. Can you lay those out for us?
Sure. You have terms like acro, which refers to the extremities, the hands and feet. Meso means the middle limb segments, so the forearm bones, radius ulna, and lower leg bones, tibia, fibula. Rhizo, as we just mentioned, is the proximal limb segments, the femur in the leg, humerus in the arm. Then spondylo always relates to the spine. Epi refers to the epiphyses. Those are the ends of the long bones right near the joints. And meta refers to the metaphyses. That's the part of the long bone where it flares out towards the growth plate.
Okay, got it. Acro, meso, rhizo, spondylo, epi, meta.
These terms are absolutely vital. They act like a precise address system for the skeletal abnormalities. So if a condition is described as, say, acromelic, you know immediately the main issues are in the hands and feet. Or Spondylometaphyseal dysplasias tells you right away that both the spine and the metaphyses of the long bones are involved. This terminology just immediately narrows the possibilities down.
And the example you included, the TRPV4-related spinal metaphyseal dysplasia, shown with those radiographs, that really brings it to life. When you look at those images, you see exactly how the terms translate, like you said. The lateral spine view shows platospondylally flattened vertebrae, that's the spinal low part.
Exactly.
The chest x-ray reveals these kind of oar-shaped ribs. The hand x-ray points to delayed carpal ossification, that's acro, and the femoral neck looks broad and short, which is a classic sign of metaphyseal dysplasia, the meta part. It really shows how this specific language combined with the imaging is like a diagnostic blueprint.
That combination, the clinical language and the imaging, it's indispensable. And it leads us straight into the diagnostic process itself. Your material really emphasizes that diagnosis requires this multifaceted approach. You're piecing together information from, well, all sorts of sources. A thorough history, analysis of the family tree, the pedigree, a detailed physical examination, and then careful analysis of all those findings.
It sounds like serious detective work. Where do you even start gathering those initial clues? The sources mention analyzing the child's growth curve as one of the very first steps.
Oh, absolutely critical. You need to plot the child's measurements, height, weight, head circumference over time on the appropriate growth charts. Ideally, you'd use charts that are ethnicity specific if they're available. And you also need to look at the growth history of the parents. Is there a family pattern of short stature, even if it seems mild?
Okay, so plotting the growth, what happens next?
Well, when you encounter short stature, there are some initial things to consider just to rule out more common, potentially treatable causes first. For instance, if a child has proportionate short stature, meaning the body segments are roughly in normal proportion, just small, but they have increased weight for their height, you'd first think about things like growth hormone deficiency or maybe insensitivity, hypothyroidism, or even glucocorticoid excess, maybe from medication. The initial workup for those conditions would typically involve a bone age x-ray measuring IGF-1 levels, checking thyroid function tests like T4 and TSH, sometimes a karyotype to check chromosomes, and specific tests for growth hormone issues. Often this requires involving an endocrinologist.
Okay, so you're checking for those usual suspects first. What about the flip side? When the weight for height ratio is decreased?
Then your suspicion shifts more towards issues like perhaps malnutrition or malabsorption syndromes, or maybe a chronic systemic disease that's affecting growth. So the initial workup would target those possibilities. Things like testing for celiac disease, that's the tissue transglutaminase test, checking serum electrolytes, maybe analyzing urine for conditions like renal tubular acidosis or nephrogenic diabetes insipidus. You're systematically eliminating possibilities based on the overall clinical picture.
Makes sense. Beyond that general health picture, what specific historical details are particularly valuable when you start suspecting an actual skeletal dysplasia might be involved?
Well, family history of short stature is obviously key, as we mentioned, but also getting a really detailed antenatal history from during the pregnancy is crucial.
Antenatal, like what specifically?
Things like polyhydramnios, that's excess amniotic fluid, or maybe evidence of decreased fetal growth on ultrasounds, decreased fetal activity reported by the mother. Sometimes that's due to restricted movement in utero because of the skeletal issues, signs of joint contractures, dislocations, or even fractures happening before birth.
Fractures before birth. Wow.
Yes, those prenatal clues can be incredibly telling. And you absolutely have to ask about the mother's drug history during pregnancy. Maternal warfarin exposure, for instance, it's an anticoagulant, but it can cause bone findings that precisely mimic a genetic skeletal dysplasia called chondrodysplasia punctata. You have to rule that out.
Okay, drug history, got it.
And here's a point the material emphasizes that's sometimes easy to overlook. A history of stillbirths or late miscarriages in the family. Even if the cause wasn't clearly identified at the time, these could potentially have been due to a severe, perhaps lethal skeletal dysplasia. That history can be a crucial clue when you're evaluating a living child in the family.
That's a really powerful point, connecting those seemingly unrelated events in the family history. The material also warns about diagnostic pitfalls, right? Where conditions might be mistaken for each other, even by specialists.
Oh, it definitely happens. More often than you might think, especially with initial evaluations or less detailed imaging. Conditions like, say, the nataphoric dysplasia and achondroplasia can look somewhat similar on scans, especially prenatally. or hypophosphatasia versus osteogenesis imperfecta. Even really severe conditions like achondrogenesis could potentially be confused with just a macerated fetus if the specific skeletal abnormalities aren't fully appreciated or looked for. That's why your source really stresses the value of reviewing any old photos, radiographs, or even autopsy results if they happen to be available and accessible. Every piece helps.
So after gathering all that history, doing the physical exam, maybe some initial general tests, how does someone actually put it all together and start narrowing down those 400 possibilities? The sources map out a pretty structured sequence for this.
Yes, a systematic approach is key. It often starts with those fundamental body measurements we touched on earlier.
Right. Measuring height accurately, calculating the upper segment to lower segment ratio, the USLS ratio, and measuring arm span compared to height.
Exactly. And these body proportion measurements are incredibly informative. They're often the first major key to classifying the type of short stature you're dealing with. The USLS ratio, for example, it changes quite predictably as a child grows. It's high at birth, maybe around 1.7 to 1. Then it decreases steadily, reaching about 1 to 1 by age 7 or so. And then it's typically lower than 1 to 1 in adults, meaning the legs are longer relative to the trunk.
Okay.
So if you see, say, a 10-year-old child who still has an infantile USLS ratio like 1.3 or 1.4 to 1, that immediately tells you something is disproportionate, and it's specifically affecting lower body growth relative to the upper body. Think conditions like achondroplasia.
I see. And the arm span.
Similarly, arm span, that's fingertip to fingertip with the arms stretched out wide, it's usually a bit less than height in young children, roughly equal to height by the teenage years, and can be slightly more than height in adults. Significant deviations in these measurements or ratios immediately point you towards certain categories of causes. Is it proportionate slow growth, like maybe hypothyroidism, or is it a disproportionate condition affecting limbs or trunk specifically?
Got it. So those ratios act like a quick screening tool, kind of pointing you in the right direction. Next, the material says you pinpoint the specific area or areas of the body with the greatest shortness. Is it the limbs overall? Is it the hands and feet? Is it the trunk, the neck, the lower back? And then within the limbs, is it that the proximal parts, the rhizo part, that are shortest? Or the middle, meso, or distal, acro?
Precisely. You're localizing the problem as much as possible through measurement and observation. And while you're doing that detailed physical assessment, you're also looking for other clues, other physical signs. You try to identify what are called secondary effects. These are essentially deformations that are caused by the underlying bone problem. Things like bowing of the limbs, maybe unusual skin dimples, overlying bone malformations, a disproportionately large head, which is macrocephaly, or maybe soft spots on the skull bones, craniotape.
Okay, secondary effects, consequences of the bone issue.
Right. And then you also look for primary defects. These are actual structural malformations that occurred during development itself, alongside the skeletal dysplasia. Things like extra fingers or toes, that's polydactyly, or cleft palate, or congenital heart defects. These are considered malformations of development, not just consequences of the skeletal problem. They can be important clues to specific syndromes.
Okay, primary malformation.
So this systematic clinical evaluation, combining history, measurements, and physical exam, it then absolutely requires imaging to go further. Your source states it very, very clearly. The number of clinical discriminators is far less than the number of skeletal dysplasias. What that really means is you simply cannot diagnose most of these conditions based on the physical exam alone, no matter how thorough. Radiographs are essential.
Right, so it's the imaging, the x-rays, that really let you see the specific skeletal findings needed for diagnosis.
Mm-hmm.
What constitutes a complete skeletal survey in this context?
It's a pretty standardized set of x-rays designed to give a good look at most of the skeleton.
Based on the material you provided, it looks like. Lateral views of the skull and the whole spine, a view of the thorax or chest, the pelvis including the hips, images of all the major long bones, humerus, radius, ulna, femur, tibia, fibula, and x-rays of the hands.
That's the standard comprehensive survey, yes. And the assessment isn't just about length or shortness. You're looking carefully at bone size, the internal structure or texture of the bone, the mineralization, how dense or perhaps undermineralized the bone appears, and the overall shape of each bone. Even areas that look relatively normal can be diagnostically important because they help rule out conditions that typically affect those specific regions.
Okay, so a really detailed look at the whole skeleton.
Yes. And by categorizing the radiographic findings using those descriptive terms we talked about earlier, spondylo, epiphyseal, metaphyseal, maybe diaphyseal involvement, that's the shaft of the long bones, or acromeso, you can dramatically narrow down the potential diagnoses. The pattern of involvement is key.
And specific examples from the images you provided are incredibly helpful here for understanding that. Like for pycnodysostosis, you see that really unusual combination of increased bone density overall. The bones look very white on the X-ray. But then you also see areas of bone resorption or osteolysis, particularly in the very tips of the fingers, the distal phalanges.
That's a classic combination for pycnodysostosis, yes. Very dense bones, but resorption at the tips.
Another really striking image is for Digby-Melchior-Clausen syndrome. This one's interesting because, as the notes mention, it's often associated not just with short stature and hip problems, but also developmental delay, which isn't a universal feature of skeletal dysplasias.
Right, that association is important.
And the lumbar spine X-ray shows that very distinctive double hump appearance of the vertebral bodies, or sometimes described as a central indentation or mid-anterior beak. Very characteristic.
Very characteristic indeed. Similarly, Langshire-Gideon syndrome, which also often involves developmental delay along with short stature and unusual facial features. That one has characteristic findings on X-ray, like multiple cone-shaped epiphyses, particularly visible in the hands, and bony growths called exostoses, often seen near the wrists, at the distal, ulna, and radius, and sometimes the knees.
Cone epiphyses and exostoses. Specific signs again.
And the pelvic views can be absolutely crucial for some conditions. For asphyxiating thoracic dysplasia, or June syndrome, which primarily affects the chest size and can cause severe breathing problems. The pelvis often shows characteristically narrow sacroiliac notches and a sort of trident shape to the roof of the acetabulum, the hip socket. Those pelvic findings can be key.
And campomelic dysplasia. The descriptions mention some features on X-ray that sound almost diagnostic on their own.
They can be highly suggestive, yes. Things like the absence of vertebral pedicles, those little bony arches on the back of the vertebrae, specifically in the thoracic spine, while they are present in the lumbar spine. Often finding only 11 pairs of ribs instead of the usual 12. And underdeveloped or hypoplastic shoulder blades, the scapulae.
The notes also mention you might see curvature of the neck or spine like kyphosis or scoliosis.
Correct. Seeing that combination of findings on a skeletal survey makes campomelic dysplasia a very strong possibility. These specific radiographic findings are like fingerprints for many of these conditions.
Okay, so we've covered the history, the exam, the measurements, and now the really detailed skeletal survey. What other tools are in the diagnostic kit? The material mentions ancillary signs and also biochemical clues.
Right. Ancillary signs are basically findings outside the skeleton that, while they might not be present in 100% of cases, can be highly specific and very helpful diagnostically when they are found.
Clues beyond the bones themselves.
Exactly. These include things like congenital heart disease or the presence of extra digits, polydactyly, or maybe dystrophic, poorly formed nails, which you might see in conditions like Ellis-Van Creveld syndrome, which combines short limbs, polydactyly, and often heart defects. But some ancillary signs are truly unique and almost pathognomonic, like the cystic swellings that can occur on the outer ears, the pinnae in infants or children with diastrophic dysplasia. If you see that, it's a major, major clue.
Cystic ear swellings. That's very specific. And the image you included showing the hand in diastrophic dysplasia is also really striking. It points out that very distinctive thumb deformity, often called a hitchhiker's thumb, because it's sort of abducted and short, and it sometimes lacks the normal flexion creases at the joint.
Yes, the hitchhiker thumb and the ear swelling are classic for diastrophic dysplasia. It's those specific, sometimes subtle details that can really make the difference in diagnosis.
Any other key ancillary signs?
Well, another important set of features often seen together is the Pierre-Robin sequence. This is characterized by a small lower jaw, micrognathia, which often causes the tongue to be displaced backwards, glossoptosis, and frequently a U-shaped cleft of the soft palate. It can cause significant breathing difficulties, especially in newborns.
Pierre-Robin sequence.
This sequence is known to occur in certain conditions that affect type 2 collagen, like Stickler syndrome. And as your source notes, Stickler syndrome also typically involves high myopia, severe nearsightedness, and hearing loss, in addition to the Pierre-Robin features and sometimes joint issues. Pierre-Robin sequence can also be seen in campomelic dysplasia, which we mentioned earlier.
Okay, so seeing that pattern alludes you to look for those specific underlying conditions. Now, beyond these physical signs, some skeletal dysplasias are diagnosed or confirmed through specific biochemical tests, right? Lab tests?
Yes, absolutely. The classic examples here are the mucopolysaccharidosis, the MPS disorders, and the related mucolipidoses. These are metabolic storage disorders where specific complex sugars aren't broken down properly. Screening is typically done by looking for abnormal amounts or patterns of these complex sugars, mucopolysaccharides or oligosaccharides, in the urine. But the definitive diagnosis for these relies on measuring the activity of the specific enzyme that's deficient. This is usually done in blood cells, like white blood cells, or cultured skin cells called fibroblasts.
Enzyme assays.
Correct. And importantly, these storage disorders often result in a characteristic pattern of skeletal abnormalities that you can see on X-ray, which is called dysostosis multiplex. Seeing that pattern would prompt the biochemical testing.
Dysplasias multiplex. That sounds complex itself. What does that actually look like on the radiographs? What are the features?
It's really a constellation of findings, a recognizable pattern affecting multiple bones. In the skull, you might see an abnormally shaped sella turcica, that's the little pocket holding the pituitary gland, often described as J-shaped. Or you might see premature fusion of some of the cranial sutures. The vertebral bodies, especially in the lower spine, often appear ovoid or bullet-shaped, and you can see irregularities or defects in how they've ossified. Ribs are often described as wide and maybe paddle-shaped or oar-shaped, often narrowing towards the back near the spine.
Okay, a whole pattern of changes.
And the images you included really illustrate this well. The X-ray of the hand in Hurler disease, which is MPS type I, shows this marked proximal pointing of the metacarpal bones. They look almost like they've been sharpened to a point at the base. Very typical.
Yeah, that's striking.
And the lateral spine X-ray in Morquillo A, MPS type IVA, shows severe flattening of the vertebrae that's platyspondyle, often with a pronounced outward curve, a gibbous deformity, and characteristic beaking or indentation of the vertebral bodies, often mid-anteriorly. Plus, there are usually significant issues in the neck vertebrae, like hypoplasia of the bends.
And these distinct radiographic patterns are highly suggestive and lead you to the specific biochemical tests.
Exactly. Other biochemical examples mentioned in your sources include specific abnormalities in sterol metabolism that can be found in some types of chondrodysplasia punctata. In those cases, certain cholesterol precursors, like 8-cholesterol and 8-dehydrocholesterol, might be elevated in the blood. And for Albright hereditary osteodystrophy, which involves hormone resistance, sometimes the diagnosis can involve measuring the function or protein activity related to the GNAS1 gene, perhaps before or alongside genetic sequencing to confirm it.
Okay, so biochemical tests for specific groups.
And then finally, though it's used less commonly in routine diagnosis these days with the advances in genetics, histology still has a role.
Histology actually looking at the bone and cartilage tissue under a microscope.
Precisely. It can still be crucial, particularly if the underlying molecular defect for a suspected condition is unknown, or perhaps for prenatal diagnosis in some situations, or when evaluating stillbirths where genetic testing might be difficult or uninformative.
So actually examining the tissue structure itself, what kind of samples are useful for that?
Your material notes that for autopsy samples, the femur is often very valuable because it includes bone, cartilage, and importantly, the growth plate, the physis, where many of these developmental abnormalities originate. For living patients, if histology is needed, an iliac crest biopsy taking a small sample from the pelvic bone can sometimes be useful.
And what are you looking for in the histology?
The histology helps distinguish conditions by allowing pathologists to examine key criteria. Where is the primary abnormality located? Is it mainly in the bone tissue itself, the cartilage matrix, or within the growth plate structure? Does the extracellular matrix, the sort of scaffolding around the cells, look normal in its composition or organization? Are the cartilage cells, the chondrocytes, morphologically normal, their shape, size, arrangement? And what are their relative widths and the organization of the different zones within the growth plate? The resting zone, proliferative zone, hypertrophic zone. Differences here can point towards specific types of dysplasia. It's like a final, detailed inspection of the fundamental building blocks.
Wow. Okay, stepping back from this really deep dive, it's incredibly clear how diverse skeletal dysplasias are and how layered and complex the diagnostic process has to be. It's definitely not just one test or one finding.
Not at all. It truly is a complex puzzle. It requires the careful assembly of all those pieces. Historical clues, subtle physical findings, those precise measurements and proportions, the detailed interpretation of skeletal radiographs across the whole body, and then sometimes delving into specific biochemical tests or even occasionally that microscopic tissue analysis. It really highlights the level of dedication and meticulous detail required to reach an accurate diagnosis in this challenging field.
And for you, our listener, providing these sources and joining us on this journey today, hopefully this gives you a real appreciation for that diagnostic detective work, and also for the immense progress that has been made in understanding and classifying this huge group of individually rare conditions. When you think about it, over 400 distinct disorders. It's mind-boggling. And despite all the advanced tools we have now, like NGS, the diagnosis can still be incredibly challenging. It requires not just the technology, but also that sharp clinical eye for subtle signs and that systematic, almost forensic approach we've walked through. What really stands out to you now about that complexity and maybe the diagnostic artistry that's involved in figuring these conditions out? Thank you so much for sharing your sources and joining us for this deep dive today.